This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may be undertaken only with prior written consent from the AARC. Copyright 2011, all rights reserved. My name is Bill Dubbs. I am the AARC Director of Education and Management Services, and I welcome you to today's webcast on pulmonary function testing. Back to the basics. Upon completion of this AARC webcast, participants will be able to identify which pulmonary function parameters are most important for spirometry, diffusing capacity of the lung volumes. They will also be able to describe suitable methods for reporting graphical and tabular data. Thirdly, they will be able to suggest appropriate predicted sets and describe how to use them. And finally, distinguish between fixed cutoffs and valid lower limits of normal. It is my pleasure to introduce to you our speaker for today, Gregg Ruppel. Gregg is a registered respiratory therapist, a registered pulmonary function technologist, and an AARC fellow. He is the director of Pulmonary Function Laboratory at St. Louis University Hospital and is an adjunct professor of pulmonary critical care and sleep medicine. Gregg has published numerous articles on pulmonary physiology and diagnostics in the peer-reviewed literature. He has presented at numerous scientific meetings. Gregg also serves in his spare time as president of the National Board for Respiratory Care Board of Trustees. Mr. Ruppel discloses that he has received consulting fees from GSK, Gilead, and Biomedical Systems, honoraria from Medical Graphics, and royalties from Mosby Elsevier. Specific products may be named as examples of technology in this program. Gregg, welcome to the program.
Thank you, Bill. You
may have to click your microphone on at the bottom left there.
Okay. Can you hear me now?
Gregg, I can hear you good.
Okay, I can hear Bill.
Okay, I think that you're good to go. Others are saying they can hear you.
Okay. Well, sorry about that. Thank you, Bill, and thanks to the AARC for inviting me to give this presentation. Bill has briefly identified what the objectives for our topic are this afternoon. And again, I want to stress the back to the basics aspects of what I'm going to present to you. We're not going to talk about anything in the future, but we're going to look at some of the tried and true aspects of pulmonary function testing the way it's currently practiced, and that is going to center on the three basic tests that most of us are familiar with: spirometry, lung volumes, and diffusing capacity. And hopefully by the end of the day you'll have some ideas that will help you provide better services to both the patients and to your physician customers. I'm going to try to, during the course of the presentation, stick to the KISS principle, which hopefully you've heard of before. It's basically a way to keep it simple. And in terms of what we're interested in here today, pulmonary function labs are really no exception. We need to keep it simple as well. And I think the first objective in terms of doing that is to think about whether or not we do tests that are really necessary for the best diagnosis of the patient. It's sometimes difficult to maintain simplicity because our computerized systems allow us to calculate lots of different variables. And I'm sure you've all seen spirometry reports that contain 20 or more variables. And for most of these, we don't have a very good idea of even what the normal limit should be. Dr. Bob Crapo, who many of you may recognize, it showed us years ago that the more parameters that you provide on a pulmonary function report, the more likely you are to find something that appears to be abnormal, and whether or not that really helps with the patient's diagnosis or not is probably questionable. So I think the key to avoiding that syndrome is to do just those tests that are necessary to answer the clinical question asked of the test. And so I've listed here some of what I consider to be important clinical questions, and hopefully these are the types of questions that you're seeing when patients are referred to your lab. Things like, why is this patient short of breath? Does he have COPD? Does he have asthma? Is the patient a candidate for some particular type of intervention like lung surgery? And unfortunately, a lot of the tests that we do don't provide a direct answer to these specific clinical questions, but they simply describe either normal or abnormal physiology. So it's even more important for us to stick to the keep it simple principle. So I'd like to start with talking briefly about spirometry and what we need to do to simplify spirometry. And again, I think in terms of all we really need are the things that you see listed here. That is, we can probably relate that we need to get acceptable and repeatable spirometry. And those of you who do pulmonary function testing as part of your daily routine will recognize that although this seems like a very simple approach, that it can be difficult to get acceptable and repeatable spirometry on many of our patients. But again, if we can get a good forced vital capacity, and if we can get an acceptable and repeatable FEV1, then we can really calculate most of what we need in terms of helping the patient in deciding whether or not obstruction is present and whether or not additional tests might be needed. I say that we can get the all-important FEV1 over FVC because, again, it's the decision point that we use for deciding whether or not the patient has obstruction. And in many instances, that's the clinical question that we're attempting to answer. And looking at that ratio, provided we have good quality data, can reliably give us an answer as to whether or not the patient does have obstruction. But there are some other potentially useful alternatives, and I just mentioned those here. One of those is the MVV, and even though that's an effort-dependent maneuver that has a lot of weaknesses, it still acts as a pretty good overall indicator of lung function. If you think about it, a subject who can move 100 liters a minute into or out of their lungs most likely has normal lung function, with just a very few exceptions. And because the MVV measures inspiratory and expiratory breathing mechanics, it can sometimes tip us off if there's a problem with the patient's inspiratory mechanics, such as neuromuscular weakness. It also can give us a good idea about how much ventilation to expect if we decide to exercise the patient, whether it's a full pulmonary cardiopulmonary exercise or something as simple as a 6-minute walk test. Peak flow is also an effort-dependent test, but it kind of performs like the MVV. If the patient has a normal peak flow, then it's unlikely that we're dealing with significant airway obstruction. So again, these kinds of simple measurements can help us determine whether or not we even need to look further. And so although they're not as important as the FVC and the FEV1 in their ratio, they can be useful. For those of you involved with pediatric pulmonary function testing, the FEV 0.75 or FEV 0.5 may be a much more appropriate parameter to record rather than FEV1, and although not as well standardized, certainly may be more appropriate for pediatric patients, particularly in young patients who have normal compliance. So again, in terms of keeping it simple, I think relying on the basic spirometric parameters is the way to go. You may or may not have seen this before, but this is the ATS-ERS interpretive algorithm that was published as part of the ATS guidelines back in 2005. And although this isn't widely adopted, I think it represents a pretty common decision tree for many people who try to interpret pulmonary function studies. You should notice that the primary decision point up there at the top is the FEV1 ratio. And you should also notice that the lower limit of normal, LLN, is suggested as really the cut point. The first question we should ask ourselves is the FVC ratio below the lower limit of normal? Note that lower limit is not a fixed number like 70%, but rather the lower limit of normal based on the lowest fifth percentile of a healthy population, taking into account the age and gender of the patient as well as their ethnicity. The second tier of decision points really relate to the vital capacity and the total lung capacity, and those help us to decide whether or not there's a decrease in the lung volumes, that is restriction, or whether or not the lung volumes are normal or increased as we might expect to see in obstruction. So by looking at vital capacity and total lung capacity and how they compare to their lower limits of normal, this simple algorithm gives us an approach to looking at the next most logical part of the diagnosis. And then the third step suggested by the ATS-ERS committee was to look at the DLCO as a way to place the patient in a further subdivision, or in one of the buckets, if you will, at the bottom of the algorithm. And so if we can answer the question as to whether or not the lung volumes are appropriate, then we can look at the DLCO to see whether or not the patient is normal, whether or not they have something related to a reduced DLCO because of asthma or emphysema or one of the other diseases that are listed in those bins at the bottom. And again, I think it's important to notice that throughout this algorithm, the lower limit of normal is used as the decision point rather than some sort of a fixed cutoff, that is a fixed % of predicted, which may not be appropriate. And I'll come back to that in a few minutes, and we'll talk a little bit about what probably should appear on our final reports. The next probably most important set of parameters that we should look at would probably be the DLCO, and that's not in the exact order that the ATS algorithm suggested that we just looked at, but I think because the DLCO has such clear indications in terms of what it can be used for in terms of answering the clinical question, that it's appropriate to consider it next. And really, we really only need to be concerned about the DLCO value itself and whether or not we need to adjust that value for any of the parameters that you see listed there. Again, the ATS-ERS guidelines recommend adjusting the DLCO for hemoglobin, carboxyhemoglobin, or for the altitude of the laboratory as appropriate. These adjustments tend to be most important when the patient has a DLCO that's near their lower limit of normal. Think about that previous algorithm that we just looked at. So individuals who have a diffusing capacity number that's close to that lower limit of normal, where we're going to make a decision as to whether or not they have disease or do not, it may be important to take into account some of those factors that need to be adjusted, such as the hemoglobin. Hemoglobin seems to exert the biggest effect, and if the patient is a smoker or has other exposure to carboxyhemoglobin, that's almost always going to decrease their DLCO. But again, that needs to be considered when we try to interpret the results or answer the clinical question. In our lab, we follow the ATS-ERS recommendations, and we adjust the predicted value. I know a lot of labs in the U.S. still adjust the measured value, but I think it's more intuitive to adjust the predicted value as recommended by the ATS-ERS guidelines. Some of the other potentially useful parameters are things like the lung volumes and the DLVA. However, I think it's important to keep in mind that the DLVA is not a correction per se, because it doesn't decrease linearly with lung volume. So we can think of it as a way of explaining a reduced DLCO, but it's in no sense to be construed as a correction in the way we think of adjusting for hemoglobin or carboxyhemoglobin. It's also sometimes useful to look at the alveolar volume measured during DLCO and compare it to the other methods, either plethysmographic or gas dilution techniques, simply to see whether or not it's reduced. And again, in healthy subjects, that is subjects who have normal spirometry, you might expect that the lung volume measured from the single breath of the tracer gas during the DLCO measurement should reflect a normal lung volume if in fact that's what the patient has. So again, these are some simple approaches to looking at a somewhat complex test. However, I think it's important to also look at what can go wrong during the DLCO and what causes the DLCO to be problematic in a lot of laboratories. What I've listed here for you is hopefully an equation that you've seen before. This is basically the working form of the DLCO equation, and the term on the right, the natural logarithm of the gases, really tells us about the uptake of carbon monoxide in the lungs. The rest of those terms are basically correction factors so that the answer comes out in milliliters of CO per minute per millimeter of mercury pressure. But as the little boxes indicate, a lot of things can interrupt the equation to cause problems. And for example, for the gases themselves, inaccuracy of the inaccuracy in the analyzers themselves can cause the gases to be measured incorrectly and cause the DLCO to be problematic. Failure of the gas conditioning devices, if you use a system that uses those, can also affect the analysis of the gas. How the maneuver is timed can affect some of the correction factors, and the inaccuracies in the flow sensor itself can affect how well we measure that alveolar volume, which again is the primary determinant of diffusing capacity. So I think if you look at the equation in this way in terms of what can go wrong, what part of the equation might be failing, many times it can help to eliminate some of the issues that we see daily in our laboratories. Let's go on then and talk a little bit about lung volume measurements. The important measurements are really the vital capacity or the forced vital capacity. If we run into a situation where the vital capacity is reduced, then it may be appropriate to measure total lung capacity. And I suspect that many of you who do complete pulmonary function tests consider the measurement of total lung capacity part and parcel of that. However, it may be worth considering that the vital capacity tells us most of what we need to know about the total lung capacity. So consider that the vital capacity in healthy subjects makes up 70 or 80% of the total lung capacity. If we know that the vital capacity is normal, that effectively rules out restriction in almost every case. So as a clinician, you should think about whether measuring total lung capacity and residual volume are going to add anything to the clinical question that's being asked of the test. In other words, if you know what the individual's total lung capacity is that going to help make a better diagnosis? Is that going to help in planning a therapy for a particular patient? And that's assuming that those things can be measured accurately. So again, that's kind of the key issue in terms of lung volumes. There are some useful adjuncts, and again, if you measure total lung capacity, then you have a way of getting at residual volume. And residual volume seems to be coming into its own as a marker of how bad or how responsive lung disease may be in patients with airway obstruction. There's some literature to suggest that measures of gas trapping, such as the residual volume, are actually as sensitive as the FEV1 if we're trying to explain why the patient has symptoms or whether those symptoms get better following inhaled bronchodilator, for example. So even without actually measuring residual volume, we can get a sense of whether or not the patient does have some sort of hyperinflation by measuring the inspiratory capacity. And again, inspiratory capacity can be measured just with a simple spirometer, and we make the assumption that if the inspiratory capacity is normal, that the patient probably has a normal functional residual capacity. However, to really answer that question, we would have to measure lung volume. So inspiratory capacity has been suggested as a surrogate for actually measuring lung volumes, and in some instances that may be an appropriate thing to do. Inspiratory capacity has been shown in some studies to relate to whether or not the patient is hyperinflated, whether that hyperinflation is responsive to bronchodilator therapy, and also to help decide on the prognosis for patients who have very severe obstructive lung disease. Again, if we ask ourselves the question, do we really need to measure TLC? The answer is, if we suspect that the patient has restriction, then in fact we may need to do that measurement. And this is kind of the conventional view that probably most of you are familiar with in terms of what we mean when we say restrictive lung disease. What we mean, if we consider the bar on diagram on the left to be normal, is that a restrictive disorder typically will affect all of the lung volume compartments, such that inspiratory capacity, expiratory reserve, and residual volume are reduced more or less in proportion. And when we see that pattern, we consider that as a pure restrictive type of disorder, keeping in mind, of course, that many different types of disease entities can result in that particular pattern. Perhaps the disease entity, or the entity that we deal with quite often in the pulmonary function lab, is obesity. And again, obesity presents a slightly different view, and it's slightly more complicated because in obesity, the classical wisdom was that it was a restrictive problem, but it's not restrictive in the sense that we would often consider. Mostly, we would be concerned that the FRC is decreased in the presence of obesity, such that the normal FRC becomes reduced, more so than either the TLC reduction or the reduction in the vital capacity itself. And so there is some literature to suggest that although obesity can result in a restrictive pattern, the main lung volumes that are affected are the FRC and the ERV. And so that those are the things that tend to be most reduced. And so again, if restriction is the question that's being asked of the lung volume measurement, then we probably do need to measure total lung capacity in order to answer that question. This is some data published a few years back by Sean Aaron and colleagues in CHEST 1999, and what they basically did was ask themselves, how often do patients with reduced forced vital capacities actually have restrictive lung disease? And you can see that in individuals who have normal vital capacity, the incidence of restriction is pretty low. However, as the forced vital capacity falls, the incidence of restriction tends to increase. However, even in individuals who have a very low vital capacity, 60% or so, only about half of those individuals show up as having restrictive lung disease. That same pattern is observed if we take obstruction into account. And again, these dotted lines represent normal FEV1 ratios, slightly decreased, moderately decreased, and severely decreased FEV1 ratios, again, the same pattern emerges. A low vital capacity is related to a reduction in total lung capacity, but as the patient displays more and more obstruction, the probability of restrictive lung disease becomes less and less. So again, a low vital capacity simply tells us that we need to probably look further. And again, that should be the primary indication in our labs for actually measuring vital capacity, total lung capacity. Let's move on and talk a little bit then about, once we've performed our spirometry, lung volumes, and total lung capacity measurements as indicated, how's the best way to present that data? And so I would suggest to you that, again, in terms of keeping things simple, what we should include on our final report should be just those tests that are related to the questions to be answered. And again, that would include spirometry, diffusing capacity, and perhaps the total lung capacity or other lung volume subdivisions, if in fact those are going to help to provide a diagnosis. Again, the guideline here is to avoid misclassification. So in order to standardize for easy interpretation, our reports should be as simple as we can make them. One of the aspects of that I think is important but often overlooked is how that data is presented. And in many instances, that data includes fixed cutoff values because those tend to be simple and easy to remember. But just the fact that all of our systems are computerized should tell us that we don't need to rely on simple, easy to remember fixed values if a more accurate way is available. And again, my suggestion to you would be that looking at things other than fixed cutoffs may be the way to go. And we'll discuss that in a little bit more detail shortly.
There was a question from one of our participants. Diana had a question, and she says there has been some controversy in our department about what order to perform each of the maneuvers when doing a complete pulmonary function test. For years, the order that I did them was FVC, lung volume, then DLC. Are there any ATS guidelines regarding the order?
That's a very good question. It seems to be a question that comes up over and over again. And if you look carefully in the ATS ERS published guidelines from 2005, you'll find that there really isn't any recommendation in terms of the order of performing the test. However, there are some references to various different studies that suggest one way may be better than another. However, nothing has been put down in concrete. I think it's important to keep in mind that if you're using a gas dilution technique like the nitrogen washout, where the patient's given 100% oxygen to breathe for several minutes, that you probably don't want to do that particular maneuver immediately before performing a DLCO maneuver. The ATS guidelines do recommend that the patient using oxygen be taken off that oxygen for at least 10 minutes before doing the DLCO maneuver to allow their blood gases to normalize. So again, there are some things like that are probably not a lot of literature to support whether or not that really has an effect, but seem to be common sense types of issues that probably should be taken into account. So in terms of the absolute order in which you can do those tests, I don't think that there's any gold guideline for that, but I think it's probably a useful thing to do the spirometry first, because that's the most standardized part of the test that we're doing in terms of making sense of the numbers for interpretation, particularly the FEV1, that if a patient is unable to complete the entire test, you probably want to make sure that you get spirometry first. doing the spirometry first will also help you answer that first decision point on the algorithm that I showed you earlier. That is, does the patient have obstruction? And so that may help color the protocol that you decide to embark upon for the rest of the test. If the patient has obstruction, then you may decide up front that yes, in fact, this patient's going to need a bronchodilator, and so I'm going to use a protocol that will allow us to do that in the most efficient way. So I wish I had a better answer than that, but I think that that's an important question, and it's something that each lab is going to have to
Greg, here's another question.
With.
I'm going to hold it, though, until you get a little further into your talk. Go ahead, please.
All right. So in terms of how to simplify our reports, this is hopefully you can tell from the left-hand column of this report that this is not in a report that may be unusual in many labs. That is that because our computerized systems can generate a lot of data, they tend to do that. And so if we look carefully at what might be wrong with this report, you can see that there's a lot of parameters, actually many more variables than are actually needed considering what we've discussed already. The second column, which is the predicteds in this case, just list the predicteds for the particular patient. They don't give us any indication at all as to whether or not what the range of values are that might be considered acceptable for those predicted values. We're simply left with the average expected value for that particular patient. So the third thing that you might be considered wrong with these is that the last column on the far right shows the percent predicted. And again, in many labs, this is the way that the data is presented. And looking at the percent predicted, again, gives us just a single number to try to help us make sense of the range of values. And so whether or not a particular value falls above or below a real clinically important cutoff is not always exemplified by the percent of predicted. You probably can see that some of the values in the percent predicted column over there are in red, and that's the software's attempt to show us that those values are abnormal. But unfortunately, many times the limit of normality for deciding what color or how to display those abnormal values is based on a fixed cutoff. So for example, many systems will display an FEF 25-75% below 80% of predicted as an abnormal value. However, we know that variable is so that parameter is so variable in the normal healthy population that it probably needs to be lower than 50% of predicted before it really falls into the lowest fifth percentile. So this is a good example of a bad report, if you will, and things that we might want to try to avoid if we're going to keep the report as simple as possible. Most of the time, we can also report graphics as part of our report, and I would submit to you that perhaps the graphics might be the most important aspect of the report, because a picture of what the patient's physiology looks like may be an easier way to digest what's going on with the patient rather than a lot of numbers like you saw on the previous slide. And so I think some of the key ingredients that should be included in the graphics that you present on your report are exemplified here. And so number one, appropriate scaling is probably the most important. I'm sure you've all seen graphic displays of flow volume curves where the flow volume loop itself is so small that it's almost impossible to tell that it's a flow volume loop. And unfortunately, that's an all too common occurrence. That's particularly problematic if you're testing pediatric patients. And I hear pediatric lab personnel all the time complain about the fact that the software that we use was designed for adults, and when graphs are displayed for our 5-year-old patients, we can't really make much sense of them because the scaling isn't appropriate. So again, it's important to make sure that the graphics are scaled so that the graphic really does portray an image that tells us something about the patient's physiology. As you see on the graph shown here, there are some dots that have been plotted by the printer, and those are the predicted values. And so again, because we don't have a history of the patient, we rely on predicted values to try to see how far above or below those expected levels this patient falls. And again, by having those displayed as part of the graphic, it simplifies deciding whether or not the patient is close to the limits of normal. The curves themselves need to be identifiable, and this is particularly the case if multiple curves are displayed. And that's true because we often display multiple efforts, or pre and post bronchodilator, or pre and post bronchial challenge values. And so again, it's extremely useful if there's the ability to make sure that those curves are easily identified. If the display or printer can do that in color, that's one method, but there are other methods as well. But some of the software leaves a lot to be desired in terms of identifying individual curves. The computer can usually put in timing marks or ticks to help us see important landmarks on flow volume curves. So for example, on this curve, the computer has interposed some ticks where the FEV1 occurred, and that again helps us to make some sense out of the FEV1, even though there's not a time base on this particular type of graphic. And then last but not least, a legend is very helpful, so that if the curves, individual curves are displayed in color, that legend can help us make some sense out of the individual graphics. Here are some examples of both good and bad graphics. And again, you should be able to say something about the quality of the efforts that the patient made, as well as about the status of their airways by looking at the graphics. In other words, the graphics should really be able to display all of the necessary data. So here you see multiple flow volume curves from a couple different patients. Which of these patients do you think has normal lung function? Well, if you consider that carefully, you could probably pretty easily conclude that the patient whose curves are displayed on the right-hand side looks like we would expect them to have normal lung function and the normal configuration of the curves, plus the curves are very, very, very repeatable. However, we can't really say whether or not the patient on the left has normal lung function or not. We can make the assessment, however, that the efforts were extremely variable, and so that data is probably not going to be very useful for answering the clinical question. Again, I think this is a simple example of the benefit of having the pulmonary function data displayed in the format of graphics on the final report. What you may or may not see very often is some means of displaying the resulting data with some sort of a bar graph that shows us where this particular patient falls. And so these are some graphics from some software that's available on the web showing one method of displaying normality and severity. And this is just an example of a 55-year-old gentleman who's got a reduced FEV1 ratio. You can see that his FEV1 ratio is about 66% of predicted, 66%. His FEV1 is 2.55 and his FVC is 3.88. The graphic here displays for us the that ratio as in the red part of the histogram, and that red part of the histogram is that lowest fifth percentile that I alluded to earlier. And so we can see that this particular individual has an FEV1 ratio that's below the lowest fifth percentile for his age, height, and race, and would suggest that this patient has obstruction. We can also see that his FEV1 is similarly in the lowest 1 percentile, suggesting that in fact this patient really does have a reduced FEV1 consistent with obstruction. And again, the FVC is low, but it's above the lower limit of normal, and so that again is useful information. Now we can use a similar approach to address severity, but here is some using the data that you see displayed here and looking at some of these different published guidelines. You can see that depending on whose guideline you adopt, you might call this individual either mildly obstructed or moderately obstructed. And so although this is a useful technique, it's not very often used, and I would propose that this is something that probably may be of some benefit as we go forward. The other distinct benefit of doing the display of data this way is that all of the different parameters can be displayed on basically the same type of scale, so that we have some graphic indicator of how low the patient is and how to best classify the degree of obstruction. In terms of predicted values, we have recommended predicted values from the ATS guidelines. They recommend using the NHANES 3 predicteds. Again, those are race specific, so you don't have to do any other correction as long as you're looking at patients that are Caucasians, African Americans, or Mexican Americans, and they cover a wide age range, and that age range has recently been extended by Sanja Stanojevic, who added some additional data so that the expanded data set now can cover pediatric patients down to age 3 or 4. Again, those NHANES 3 reference equations come complete with lower limits of normal that represent the lowest 5th percentile, and again, that allows us to use that statistically valid method to try to decide who's normal or who's not. The NHANES 3 values have also been evaluated by John Hankinson recently as part of a second study, and that study looked at Asian Americans as well and decided that the adjustment factor for Asian Americans probably should be something like 0.88 times the Caucasian values if the NHANES 3 Caucasian values are used. And again, that applies mainly to Chinese Americans or second generation Asian Americans. Again, the vital capacity and forced vital capacity should both be based on the same value there. Last but not least, I think there are probably some basics that you probably might want to consider not using. This is some data from a study that I was involved with that was published earlier this year, and we looked at a large number of patients referred to 3 different labs in the United States, New Zealand, and Great Britain. And when we used that algorithm that I showed you earlier, the ATS-ERS interpretive algorithm, and applied fixed cutoffs and compared that to applying the lower limits of normal based on the lowest 5th percentile, what we discovered were that there were some significant differences, and those differences basically showed up as a large number of false positive values in individuals who are elderly, whether males or females. And so the graphics that you see here, the dark bars for males and the dark bars for females represent the patients who would be misclassified as having obstructive lung disease using a fixed cutoff of 70% for the FEV1 ratio and a fixed cutoff of 80% as the delineating line between mild and moderate obstructive lung disease. You'll probably also notice that there are some false negatives as well. Again, using the fixed cutoff of 70% would cause you to overlook some younger individuals who might have obstructive lung disease or the early signs of obstruction, whose FEV1 ratio is above 70%, but does fall below the statistically valid lower limit of normal. So in the entire group of patients that we looked at, over 11,000 patients, about 23% of them were misclassified if the fixed cutoffs were used. And again, I think this is good evidence that suggests that we need to change the way we think about how we report the data from the pulmonary function lab. So I'd like to kind of wind up and summarize by reminding you that I think it's important to keep things simple. That means that we should probably build our protocols around just those important tests that help us to really answer the clinical questions asked of us. That is the FVC, the FEV1, the ratio of those two numbers, and then DLCO and lung volumes as indicated. And it's extremely important to keep the reports as simple as possible so as to not misclassify patients, and that the use of graphics, particularly graphics that can allow us to show how much variability there is in the normal healthy population, can be very important. And then last but not least, I think it's probably important that we think about the best way to present that data, and the way that most of us do it now in terms of using percents of predicted and fixed cutoff values may not be the best in terms of making the best diagnostic decisions for patients, particularly patients that have obstructive lung disease. So I'm going to stop at that point, and I'd be happy to try and answer some of the questions if we have time.
We do have time, Greg, and that was a great overview. And I would encourage those of you that have not yet asked your questions to do so. Just type them into the participant window there, or type them into your text messaging there. And Greg, we have some I want to get started with right away because we have about 10 minutes left here. Okay. There was a question related to any tips on the best way to coach patients to do maneuvers to obtain the best results. Is it simply as much? Go ahead.
Excellent question. Unfortunately, that's a question that many folks, even people with some experience in doing spirometry, tend to overlook. And I think the key ingredient is to make sure that the patient takes a big breath in before they do the maximal forced exhalation. Again, I'm referring back to doing good acceptable spirometry. In many instances, or if you're using a spirometer in which the patient has to put the flow sensor in their mouth after they've taken the big breath in, you have really no way of knowing, did the patient really take a big breath in? In other words, are they really exhaling beginning from total lung capacity? And that's what we want them to do. We want to make sure that when they blow out as hard and as fast as possible, and we measure the FEV1 from that maneuver, that they started that maneuver with their lungs full. So it's very useful if you can monitor the inspired volume. And most of the laboratory type spirometers that I use allow you to do that. In other words, the patient is breathing on the mouthpiece, and we can watch them take a big breath in, and we can see whether or not they take a subsequent big breath in when we have them do the forced inspiratory maneuver. But if you're using a bedside spirometer, or a spirometer that only allows you to measure exhaled volumes, where the patient has to take a big breath in and then quickly place the flow sensor between their teeth and lips, you may miss whether or not they got a big breath in, or whether or not any gas leaked out before they began. So again, I think in terms of spirometry, in coaching the patient, it's very important to look at the patient and try to monitor as best you can that breath that occurs right before the maximal forced exhalation. And patients that do variable measurements many times do that because they don't really get a big breath in to start with. And the thing that I most often end up coaching patients when I do testing is, okay, let's do that test again, but this time I want you to take even a bigger breath in. And after repeating that several times, many times the patient's vital capacity increases, and as a result of that, the FEV1 gets better as well. So in terms of spirometry, I think that's probably one of the key things to keep in mind. hopefully that answered that question.
Yes, it did. I'm sorry I had my microphone off. Another question is, when is it recommended that we perform a slow vital capacity if it is always done after the FVC and obstruction is present?
Well, it's a good idea to do a slow vital capacity, and the ATS-ERS guidelines for lung volume measurements recommend that we do what they refer to as a linked vital capacity. And that means that while we're measuring the patient's FRC, whether we do that in the body box or using a gas dilution technique, that while they have the mouthpiece in their mouth, either before we do the maneuver or immediately following the maneuver, that we should probably do a slow vital capacity maneuver, either by having the patient exhale the residual volume and then fill their lungs, or just the opposite, fill their lungs and then empty that. And the idea being that slow vital capacity then should give us some idea of what the lung volume compartments look like at the time that we're measuring FRC. And again, that's extremely important if you're going to use those lung volume compartments to then calculate total lung capacity and the residual volume. Even if you're not doing lung volume measurements, even if you're doing spirometry, it's very useful to measure the vital capacity or slow vital capacity, because as most of you are probably aware, patients who have obstructive lung disease many times will compress their airways during the forced vital capacity maneuver, and the forced vital capacity may be smaller than the slow vital capacity. And we want to make sure that we look at the patient's largest vital capacity, and that in many cases may be the slow vital capacity. In Europe, the common practice is to calculate the FEV1 ratio based on the largest vital capacity that's measured, and typically that may be the slow vital capacity. And so again, that's why the algorithm says FEV1 over VC. So I think there's a lot of good reasons for measuring the slow vital capacity, and I've just mentioned a few of those, and hopefully if you're not thinking about that at the time you're doing the testing, you may want to consider that or adding that to the test if you're not doing it already.
Greg, are there any specific recommendations when doing PFTs with trach patients? Any pointers that you can mention?
Well, that's a very interesting question, and we've only got about 5 or 10 minutes left, and I don't know that I could really address that. We do some trach patients in our lab, and we really tailor each one of those tests to the specific clinical question that's being asked. So if the physician who refers the patient wants to know what the patient's FEV1 is, then we tell them right up front, if you want us to measure the FEV1 through the patient's tracheostomy tube, you're probably going to get a number that's not really very meaningful. However, if the patient can remove the tracheostomy tube and exhale forcefully through the stoma, then you may get a number that may represent something that resembles a real FEV1. If you're interested in measuring diffusing capacity or lung volumes, that almost requires that you have some way of sealing off the airway, either by using the patient's tracheostomy tube with a cuff on it, or taking out the tracheostomy tube and putting some sort of a device over the patient's stoma, which hopefully can be sealed in order to allow you to measure the DLCO or lung volumes. And that can be done in our lab when we can remove the tube, or if the patient just has a stoma. We've found that pediatric resuscitation masks can many times be held over the patient's stoma to allow connection to the breathing valve or to the flow sensor to allow things like the slow vital capacity to be measured, even to do body plethysmography or diffusing capacity tests. But again, I think the key thing here is that you have to evaluate the patient, you have to consider the clinical question that's being asked, why is this test being requested, and then try to use the most appropriate means of connecting to the patient's airway.
Okay. Greg, there's one here about when doing a complete pulmonary function test with BD, I'm not sure what that is it recommended to administer bronchodilators?
With
BD.
I'm not sure what, if
BD,
I understand.
she says.
Oh, with bronchodilator.
Bronchodilator, okay.
Oh.
Okay, so yeah, at what point when doing a complete PFT with bronchodilators is it recommended to administer the bronchodilators? That's the question.
Okay, I see. That's a topic of some that comes up quite often. One of the ATS guidelines suggested that you could administer the bronchodilator while the patient is bronchodilating, then go ahead and measure diffusing capacity. However, the diffusing capacity guideline didn't really mention that. So there's some discussion as to whether or not it's appropriate to do spirometry and lung volumes, then administer a bronchodilator, and then while the patient is bronchodilating to do tests like the DLCO. Some labs have chosen to do that. I think that because most of the bronchodilators that are used have a minimal effect on the cardiac output, that there's probably not a great deal of change in diffusing capacity that's done post-bronchodilator, but it's probably important that you somewhere on the report indicate to the interpreting physician that the patient's DLCO was measured after the administration of bronchodilator. In our lab, we simply make sure that those DLCO measurements, whether adjusted or unadjusted, show up in the post-bronchodilator column, and we make sure that the physician interpreter is aware of how the test was performed. If we have plenty of time, we usually opt to not do that, but in the interest of time, sometimes it's more efficient for the patient and everyone involved to do the DLCO while the patient is bronchodilating. And I don't think that there's a great deal of information available to support or deny doing it one way or the other.
Okay, Greg, we have time for one last question here, and it's about what about reporting the FEF over FIF50? Do you think it is useful?
That parameter is useful only if you don't have a flow volume curve to look at. Okay. And as I tried to point out in the presentation, I think presenting a flow volume curve as part of the final report probably conveys the same information that you would get from that FEF to FIF ratio, but it does so in a much, much better way. Again, that ratio supposedly will help you decide whether or not there's a decreased flow during the inspiratory part of the maneuver compared to flow during exhalation. And I think it's much simpler and much more appropriate to convey that information as a flow volume curve, keeping in mind that you have to make sure that you select the inspiratory part of the flow volume display that reflects what the patient's actually capable of doing. And so just accepting the the inspiratory loop that accompanied the best expiratory maneuver may not always be the most appropriate display of that information. Most of the software allows you to mix and match so that you can take the patient's best inspiratory effort and combine that with the best expiratory effort. Again, the expiratory effort should be the one with the largest sum of FEV1 plus FVC. The best inspiratory effort, in my opinion, would be the one that has the largest inspiratory flow. So that's not an easy question, but I think the flow volume loop display is a much better way of conveying whether or not there's upper airway abnormality.
Greg, I want to thank you. Again, you have provided our participants with excellent information, and I'm so sorry that we can't get to the rest of the questions that we had today because we did have a few others. But for those of you, let's see, to complete, hang on just a second here. For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you're watching this program as an archive, this concludes our presentation.